Welcome back to Chapter 5. In this chapter, we're going to talk about how cells are stressed, injured, and eventually die. Because long before an organ fails, it fails here first. Today, we're going to talk about hypoxia inside the cell and what ischemia really means for cells. Understanding this chapter will help you really understand the idea of shock, cardiac arrest, and tissue damage. If you want to actively go through this chapter and all the other chapters, you can always download the digital workbook down below in the description. Let's get started. Chapter 5. Cellular stress, injury, and death. Section 1. Hypoxia at the cellular level. You're called for a patient with severe shortness of breath. They're working hard to breathe. Their oxygen saturation is low, but not crashing yet. You apply oxygen, assist ventilation, and transport. On the surface light, this looks like a respiratory problem. But the real crisis isn't happening in the lungs. It's happening inside the cells. Hypoxia doesn't mean the body has no oxygen. It means cells are not getting enough oxygen to meet their needs. That distinction matters. A patient can be breathing. Oxygen can be present in the blood, and cells can still be starving. To visualize this, imagine a factory that runs on electricity. As long as power is steady, machines run smoothly. When power drops, the factory doesn't shut down instantly. Emergency lights come on, non-essential machines shut off, output slows. The factory is still running, but it's struggling. That's what hypoxia looks like at the cellular level. When oxygen delivery drops, mitochondria can't produce enough ATP. Cells switch to emergency power. They prioritize survival over function. Repair slows. Communication weakens. Energy-intensive tasks shut down first. At first, this is reversible. If oxygen delivery improves quickly, cells can recover. But emergency power is inefficient. It produces far less ATP and creates acidic waste. As acid builds up, enzymes stop working properly, membrane pumps weaken, electrolyte balance begins to drift. This is why hypoxia causes more than just shortness of breath. It leads to confusion, weakness, poor coordination, and eventually loss of consciousness. These are signs that cells, especially in the brain, are running out of energy. From an EMS perspective, this is critical. Hypoxia is not a number on a pulse oximeter. It's a state of energy failure. Two patients with the same oxygen saturation can be in very different levels of cellular distress depending on perfusion, hemoglobin, and metabolic demand. This also explains why oxygen helps early and helps less later. Early oxygen restores ATP production and stabilizes cell function. Late oxygen arrives after cellular systems have already begun to fail. The longer hypoxia lasts, the harder it is for cells to recover. The key idea here is simple. Hypoxia is a problem of energy, not air. When cells can't make enough ATP, everything else starts to fall apart. That's why recognizing and correcting hypoxia early matters far more than chasing perfect oxygen numbers later. Section 2. Ischemia and reperfusion. You respond to a patient with chest pain that suddenly improved before you arrived. Their skin color looks better. They say the pain passed. The monitor still worries you. You know this story doesn't always end well. What feels like improvement on the outside can hide ongoing injury on the inside. Ischemia means inadequate blood flow. When blood flow drops, oxygen delivery drops, but so does nutrient delivery and waste removal. Cells don't just lose oxygen, they lose their entire support system. Ischemia is more severe than hypoxia because nothing is moving in or out the way it should. To picture ischemia, imagine a busy city where all the supply roads are blocked. Fuel doesn't arrive, garbage isn't picked up, production stops, emergency power kicks in, but waste begins to pile up. The longer the roads stay closed, the more damage accumulates inside the system. When blood flow is restored, we call that reperfusion. At first, reperfusion sounds like the solution, and it is necessary for survival. But reperfusion also brings a sudden rush of oxygen and inflammatory signals into cells that are already damaged and unstable. Think of turning full power back onto a factory that's been running on emergency systems. Sparks fly, fragile machinery breaks. The restart itself causes damage. That's reperfusion injury. At the cellular level, ischemia weakens membranes, depletes ATP, and disrupts electrolyte gradients. When oxygen suddenly returns, unstable mitochondria produce harmful byproducts called free radicals. These molecules damage proteins, membranes, and DNA. Inflammation increases, swelling worsens. This is why patients can deteriorate after circulation is restored. It's why pain can return, rhythms can destabilize, and organs can fail even after blood flow improves. Reperfusion is essential, but it is not gentle. From an EMS perspective, this explains several things. It explains why sudden symptom relief doesn't always mean the problem is gone. It explains why careful reperfusion matters in conditions like cardiac arrest, stroke, and shock. And it explains why early intervention is better than delayed rescue. The goal in EMS isn't just to restore blood flow, it's to restore it before cells become too fragile to handle it. The longer ischemia lasts, the more severe reperfusion injury becomes. The key takeaway is this: ischemia injures cells by starving them. Reperfusion can injure cells by overwhelming them. Timing matters. Early recognition and early correction reduce both sides of this injury. Point 3. Cellular swelling and rupture. You're treating a patient who was down for an unknown amount of time. They're hypotensive, altered, and not responding the way you expect. You're doing all the right things: oxygen, airway support, fluids, but the patient continues to decline. It feels like the body just isn't responding anymore. This is often the moment where cellular injury has crossed a critical line. One of the earliest and most dangerous signs of severe cellular injury is swelling. Cells are designed to tightly control water movement. As long as membrane pumps have energy, water stays balanced. When energy production drops, that control is lost. To visualize this, imagine a boat with a bilge pump. As long as the pump has power, water that leaks in gets pushed back out. The boat stays afloat. If the power fails, water begins to accumulate. At first, the boat still floats, but as water continues to fill the space, stability is lost. That's what happens to cells. When ATP runs out, membrane pumps fail. Sodium moves into the cell. Water follows sodium. The cell begins to swell. At first, this swelling interferes with function. Electrical signals weaken, oxygen diffusion slows, chemical reactions become inefficient. As swelling continues, pressure builds inside the cell. Organelles are compressed, mitochondria become damaged, waste accumulates. At this stage, injury may still be reversible if balance is restored quickly. If swelling continues unchecked, the membrane eventually ruptures. The contents of the cell spill out into the surrounding tissue. This is catastrophic. Once rupture occurs, that cell is permanently dead. From an EMS perspective, this helps explain why some patients stop responding to treatment. Early injury is functional and reversible. Late injury is structural and irreversible. Oxygen and perfusion can save struggling cells, but they cannot repair cells that have already ruptured. This is also why swelling causes secondary damage. When cells rupture, they trigger inflammation. Neighboring cells are exposed to harmful substances. Injury spreads beyond the original area. What began as a localized problem becomes a systemic one. You see the effects of this in conditions like severe hypoxia, prolonged cardiac arrest, crush injuries, and severe shock. The longer cells remain without energy, the more swelling progresses, and the less likely recovery becomes. The key idea here is that cellular swelling is a warning sign. It tells you the cell is losing control, but hasn't completely failed yet. Rupture means that window has closed. Early intervention aims to stop swelling before it reaches that point. Point 4. Apoptosis versus necrosis. You're caring for a patient with a long history of chronic illness. Their condition has been slowly worsening over months. Compare that to another patient who suffered a sudden cardiac arrest and was down for several minutes. Both involve cell death, but the damage they cause to the body looks very different. That difference comes down to how cells die. Not all cell death is the same. The body has a controlled way to remove cells that are old, damaged, or no longer needed. This process is called apoptosis. Apoptosis is planned, organized cell death. The cell essentially shuts itself down in a clean and orderly way. To visualize apoptosis, imagine a building scheduled for demolition. The power is shut off. The area is cleared. The building is taken down carefully, piece by piece. Surrounding structures remain intact. Cleanup is controlled. That's apoptosis. The body uses it every day to maintain balance and health. During apoptosis, the cell shrinks. Its contents are packaged neatly. Nearby cells and immune systems remove the debris without triggering widespread inflammation. This kind of cell death doesn't harm surrounding tissue. In fact, it's essential for normal function and long-term survival. Necrosis is very different. Necrosis is uncontrolled cell death caused by overwhelming injury. This happens when cells are deprived of oxygen, crushed, poisoned, or severely damaged. The cell doesn't shut down cleanly. It swells, ruptures, and spills its contents into the surrounding tissue. Imagine a building that explodes unexpectedly. Debris flies everywhere. Nearby structures are damaged. Fires break out. Cleanup is chaotic. That's necrosis. It triggers inflammation, spreads injury, and often worsens the original problem. From an EMS perspective, necrosis is what you worry about in acute emergencies. Prolonged hypoxia, ischemia, severe trauma, and shock all push cells toward necrosis. Once necrosis occurs, damage extends beyond the original injury because inflammation and swelling affect nearby cells. This distinction explains why timing matters so much. Early intervention can reduce stress and allow cells to recover or undergo controlled processes. Delayed intervention allows injury to escalate into necrosis, where damage becomes widespread and difficult to reverse. You see this difference clinically. Chronic conditions often progress slowly with controlled cell loss. Acute emergencies deteriorate rapidly because uncontrolled cell death spreads injury through tissues and organs. The key takeaway is this: apoptosis is controlled and contained. Necrosis is chaotic and destructive. EMS care is about preventing conditions that push cells from stress into uncontrolled death. Section 5. Why early oxygen and perfusion matter. You arrive on scene to a patient who looks sick but not yet critical. They're breathing fast, their heart rate is up, and their blood pressure is just holding on. They're talking to you, answering questions, and still protecting their airway. This is the patient who gives you a choice: act early or wait until the body forces your hand. At the cellular level, this is a race against time. Cells can tolerate stress for only so long before injury becomes permanent. Oxygen and blood flow are what allow cells to keep producing energy and maintaining control. When either one drops, the clock starts. To visualize this, imagine a phone running in low power mode. At first, it limits background tasks. The screen dims, performance slows, but the phone still works. If you plug it in early, everything returns to normal. If you wait too long, the phone shuts off completely. Once the battery is dead, plugging it in doesn't bring it back instantly, and sometimes it doesn't recover at all. That's how cells behave. Early oxygen and perfusion restore ATP production, stabilize membranes, and preserve electrolyte balance. Cells recover. Function returns. Late intervention arrives after swelling, membrane failure, and inflammation have already taken hold. At that point, damage may continue even if oxygen and blood flow are restored. This is why early EMS care is so powerful. You're not just improving vital signs, you're buying time at the cellular level. You're preventing hypoxia from turning into ischemia, swelling from turning into rupture, and stress from turning into necrosis. This also explains why waiting for obvious collapse is dangerous. By the time blood pressure drops or mental status changes, cellular injury is already widespread. The window for easy recovery has closed. What looks like a sudden crash is the end of a process that began much earlier. From an EMS perspective, this reinforces a core principle. Support oxygen delivery and perfusion early, even when the patient still looks okay. Address airway, breathing, circulation, and temperature before the body runs out of reserve. The key takeaway is simple but critical. Early oxygen and perfusion don't just make patients look better, they prevent irreversible cellular injury. In EMS, timing isn't just about speed, it's about preserving life at the smallest level. Well, that wraps up this lesson. If you're working through the course, you can click the top tile to go to the next chapter. And don't forget to get the digital workbook that goes through every one of these chapters so you can actively learn them. The link is in the description down below. We'll see you in the next class.